During the COVID, the challenges of health system, Indian public health system came into open. Though there were certain positives, but we realized that we need to strengthen our government health system because in moments of crisis, it is the public system that delivers. Now, what was expected was that subsequent to COVID, public spending on health, which is one of the lowest in the world in India overall, would increase significantly. What we see in reality is that post-COVID, the union government has started bringing down, cutting back its public spending. In fact, as percentage of GDP, when in COVID 2021, 0.42% of GDP was spent on health, we see subsequently a continuous cutback, and in 2024 budget, 24-25 budget, post the new government came in, we saw that this has come down to 0.29% of GDP. And also as a share of government budget, health allocation has come down. This is deeply concerning because as we will discuss in subsequent section, that there are certain important schemes that the central government runs have been continuously cut over this period. The other point I want to make here is that earlier, more than three-quarter of union government's health budget used to go to states. Now that share has also come down to less than half. This is again deeply concerning, given that much of the health responsibilities lies with state governments, healthcare delivery responsibilities lies with state government. Union government need to transfer greater share of its budget to health. The two key points. One, overall allocation on health has come down. In real terms, it has not increased. As percentage of GDP, it has tanked significantly. As percentage of budget, it has gone down significantly. More concerning is that union government is giving less and less money to state government. So we need to really critically look at these trends because this will have severe implication on health of the people. If in the last 20 years, if you look at union government intervention on health, one of the most important vehicle have been the National Health Mission. Actually, the kind of improvement in maternal and child health that NHM has brought in was quite unprecedented in India. And through across the state, NHM has been very important scheme. Now the NHM window, National Health Mission window, has been expanded. Now we have urban component, we have non-communicable diseases coming into it, and also climate change. Some of the climate and health related interventions are also supposed to be done through the NHM. So the point is the NHM window is expanding. And then you have very important primary care intervention, which is health and wellness center, also under the NHM platform. So we would expect that given the scope of NHM has increased, that allocation would also be increased. But what we see in shocking terms at that in real terms, what was spent in 2019-20 has not been allocated in 2024-5. This clearly means the services, the kinds of medicines, the salary of ANMs, ASHAs, the honorarium to ASHAs, all the things that NHM does, the Janani Suraksha Yojana payments to mothers and ASHAs, all of that will be curbed. And this has been happening continuously. Now, one argument here is that the state governments are also, their share has increased. But that has increased, in fact, in 2018-19. Since then, it has remained the same. So you need to really push up NHM expenditure because the priorities, the concerns that NHM tries to deal with are very crucial. Ayushman Bharat expansion, Ayushman, like many other central government schemes, have been imposed on states, and states are now contributing to more than 40% of this total spending. And many of the states have also expanded the coverage of Ayushman PMJ, I'm talking about Prime Minister's Jan Arogya Yojana, because Ayushman also has a very crucial component of health and wellness center. I have mentioned health and wellness center, and it's an important intervention. But the PMJ component, which is essentially a sort of insurance or assurance scheme to use public money to actually provide care through private sector. This is some sort of biggest scheme of privatization. Now, there are significant challenges with Ayushman Bharat. What is happening in Ayushman is, as we hear from various states, that when states expand Ayushman coverage uh, to non-poor, particularly with a contribution, we see that Ayushman utilization increases considerably. And many of the states like say Haryana, Maharashtra, where the similar schemes have been, Rajasthan, have been expanded for non-poor, they are taking out a lot of budgetary allocation for on the scheme. So other schemes are suffering because of high utilization of Ayushman money. Now, the challenge, what is the problem? Problem is, first of all, if you look at RTI data and news reports, much of the poorer sections of the society who were supposed to be catered by the scheme are not being covered, particularly in the private sector. Only 3 to 4% of the private sector utilization is by Dalits, or less than 1% by scheduled tribes. So you can clearly see that the better off sections are benefiting this public provided private finance care. Regarding out-of-pocket expenditure, I want to mention two things. It's a very important question. One is the question related to uh, the question related to Ayushman Bharat, and has it led to out-of-pocket expenditure decline? If you look at, we don't have latest data, but there are some primary surveys done which shows that actually people end up paying a lot of money even though government is subsidizing the private sector. So hospitalization costs for people have increased considerably. At the same time, utilization of care has also declined. Now, this clearly is counter-intuitive to the Ayushman claims. We need, again, another nationally representative NSS kind of survey to have more conclusive evidence, but also the consumer expenditure survey, which has come out in 2022-23, shows that share of health spending as the overall household budget has increased considerably. But right, as you have rightly pointed out, our national health account numbers are showing that out of pocket is declining. How come this decline? There are a few things I want to point out. First of all, the NHA, National Health Accounts out-of-pocket numbers are calculated based on the 2017-18 NSS, National Sample Survey data. That data had certain unprecedented trends. One was that the utilization of healthcare, say utilization or say hospitalization rate, in the sense per 1,000 people, how many went to hospital, show shows a clear decline from 34 per thousand to 27 in 2017-18. This is unprecedented. We have to keep in mind that this was the time when there was demonetization, there was huge slump in rural consumption expenditure. So people might not have gone to hospital at all, or there could be data issues. Now you are using that data to extrapolate for various years. Tell me, how can we have 2017-18 trend to be projected for out-of-pocket expenditure during COVID time? We are the National Health Accounts, the NHSRC is actually projecting pre-COVID trends to COVID out-of-pocket expenditure. This is highly problematic because the COVID had an unprecedented period. So we really cannot take this out-of-pocket decline numbers very seriously. I've spoken about it in in more detail, but I think the decline is based on a data which in itself has a problem of underreporting of out-of-pocket expenditure and utilization. two important observations I want to make regarding this. First of all, health care, much of the healthcare responsibility is with the state governments. Mm. Now, so whether to look at union budget and expect it to improve human resources has limited scope, first of all. It does some infrastructural improvement, but beyond that, it's only through NHM that union government can intervene through human resources. Now, the WHO or the global standards doesn't take into account the Ayush providers, all Indian system of medicine provider and homeopathy provider. What our government is doing is also adding the Ayush providers to total doctors pool. Now, this can be debated, but definitely the comparison level of comparison is not similar. So we need to take that into account that we are comparing apples and oranges. We should not do that. Other point is, even if you take Ayush numbers into account, you will see that there are huge disparities across states. Whereas our national number with Ayush included looks like it has global standards, it has achieved global standards. You will see that states like Bihar, Jharkhand, Chhattisgarh, Madhya Pradesh, to some extent Odisha, has much lesser number of, and Northeast have much lesser density of doctors compared to some of the west and southern states. So there is a deep rooted distribution question, and this inequity across states has largely been fueled by privatization of medical education, whereas public investment on medical education has not increased. So we need to really set up public or have more number of doctors in places where there is a shortage rather than seeing this as a national whole. Because private sector doctors who are trained in private sector paying more than 1 crore rupees are very unlikely to go and serve a rural area in a remote state or a small town. They are flocking in the bigger metropolitan cities and state capitals. So there are huge disparities in availability of doctors particularly, but in general, human resources. What are our expectations? There are a few critical expectations that we have. First of all, the NHM budget should be expanded considerably. This needs to be done also taking into account that states are spending more on NHM, but still, because NHM window has expanded, the union government need to put in more money. Health and Wellness Center, which is an important scheme that is making some bit of difference at the state level. We really cannot say how much is being spent on Health and Wellness Center, but that is definitely a priority. In most of the states, health and wellness centers have not been functioning at the adequate level because human resources, the supplies, the diagnostics, the medicines have not been provided. It's just that the leveling has been changed. So real concrete work needs to be done on health and wellness sector. We need to also, union government has a responsibility of health research. And that's a critical responsibility. Only 3% of the union budget goes into health research. That needs to change significantly, and we need more funding from union government on health research. The other important element, I would say, that the production of pharmaceuticals, PSUs, central public sector units today need more money on vaccine production of vaccines, production of antibiotics. See, we face huge shortage of multi-drug resistance, tuberculosis drugs. We have to depend on imported drugs. Here we see a lot of role from the central government to introduce compulsory licensing and use central PSUs to produce medicines of critical public health importance. And central government has done away with those responsibilities, and it needs to re-emphasize on this. Yeah, these are some of the things I expect the Union government to do. The other crucial point I would mention is that there is a need to strengthen the health data system, the integrated disease surveillance program, IDSP. Some of these needs to be put in more resources and strengthened. We are emphasizing a lot on digital health, which has its own place, but the basic infrastructure, the basic data systems are not in place, and we need to strengthen those. And that's where union government has a critical role to play. Government has to come up to at least 1% of GDP from its current level of 0.29%. So a long road ahead, and it needs to be done systematically over the years.